front. I don't want to spend any more time. We have Dr. Vasan with us tonight, who's an executive director with the New York City Department of Health. He's going to describe the fascinating work that he does in light of how public health is changing to respond to some of the social demands and needs of the vulnerable communities that it serves. So without any further ado, I'll let him take over.
Hey everybody. Thanks for being here. It's cold and dark and you're so far away. I wish you were closer. Please come. Please come closer. Okay, that was failed attempt. It's okay. I teach at Columbia. I teach in the public health school at Columbia, and it's hard to get people to come to the front. So you're the same. So as Chris said, I am a director at the health department, where I joined about 2 years ago, a little more than 2 years ago, from Columbia, where I was full-time faculty there, to start a new bureau called the Health Access Equity Unit. And I use the word special populations here in this talk to kind of talk about the populations that we've historically overlooked or have a hard time making visible with regards to our public health approaches. I'll also say that our unit sits at the interface of clinical systems and public health. How many of you are clinicians, plan to be clinicians, know a clinician? Not the last one. How many of you are clinicians? Anybody? 1, 2. How many of you plan to go into some clinical area, nursing, medicine? 1. Okay. And the rest of you are all going to be epidemiologists, right? Right. Okay. Great. So, a lot of my comments you'll hear today are focused very much at that intersection of public health, population health, and clinical systems. Why? Because it's very hard to leverage population health change without accounting for what in this country, a $3.5 trillion industry is doing, right? Now we can argue about why we spend so much on healthcare. Do we spend too much on healthcare and not enough on prevention, or the drivers of health, what produces health? I would say yes to all of that. But for the moment, we're operating in the current state of affairs. And the current state of affairs is that we miss a lot. And yet there's a lot of need amongst particular communities that we don't have the ability, from the perspective of health systems or public health, to really find, to demonstrate what their needs are, and to bring them into our systems. And so what ends up happening is they appear at moments of real vulnerability, right? They appear at moments of real crisis, like when they go into an emergency room, or when you're hospitalized, or when they end up in a homeless shelter, right? These are crises, these are failures, as I think of them, as systems failures, right? Something went wrong much further upstream if you're appearing in my emergency room for something that didn't need to be there, right? I mean, obviously there are real emergencies where you need to come, but there's a lot of unintended or unnecessary use. So when I talk about a special population, I'm talking about populations that, by virtue of where we place them, how we push them, structural violence, structural racism, a whole host of factors sit at the margins of society. These are populations that have real needs, like disproportionate need. And when I say need, I mean social need, medical need, compared to the general population. And as a result of both this marginalization and that need, they're hard to engage in the systems. And so we're going to talk a little bit about what my bureau does at the city to sort of craft approaches to do that. As I said, they're often invisible to our clinical and community systems. They face disproportionate illness and trauma. I'm going to really focus a lot of at the end of the talk on trauma. And they have very unique and specific needs from lived experience of incarceration, lived experience of immigration and being a refugee, or trauma in a home country, your lived experience of war, being a veteran, right? So, or being an undocumented person in this country. So there's a lot that clinical systems and public health systems are not well attuned to do. We kind of take one-size-fits-all approaches, right? Like, you've got diabetes, you've got diabetes, you've got diabetes, we're going to treat you all the same. But actually, there's a lot of nuance. As a primary care provider, I still see patients up at New York Presbyterian once a week. you're not the same, right? I may give you the same medication, but there's a whole host of factors driving if you take that medication, why you take that medication, how you respond to that medication, whether that medication is feasible for you, right? Whether it fits your lifestyle, fits your cultural needs, your cultural understanding of what the illness is. So there's so many specific needs resulting from lived experience that these special populations face that we don't account for, and we need to start accounting for. Any questions? Interrupt me at any point. Don't fall asleep. Just trying not to fall asleep. Why special populations? Why do we do this? Well, we saw a gap. Our commissioner, our ex-commissioner, sadly, was quoted when she started as saying, inequities in health are unfair, unnecessary, and avoidable. New York City is the most unequal city in the United States, and also one of the most segregated. It's no surprise that these everyday realities are reflected in our health, and a more deliberate effort to name and address these disparities will frame all that we do. And so she made those comments around racial justice, right? She named those comments around naming racism as a driver of health. But you can extend that analogy to these special populations too, right? Like, we have to name immigration status, not name it as an individual level, but name it as a problem. We have to name our criminal justice system. We have to name war and our veterans that fall through the cracks. We have to name those things. We have to name the issues of housing and homelessness in our city as drivers of health. So we have a moral and an equity frame. We also have a social frame, right? It's not just about health as viewed as a set of conditions. It's about the other systems that are touched by people, as I said, when they have a crisis or a failure, right? Folks touching our emergency rooms, but also touching our shelters, touching our benefits systems. There's an epidemiologic view, and this is part of where public health needs to get better. We need to incorporate measures of these populations into our surveys so we can define the problem, right? Everything starts with the denominator. You need to know who you're dealing with, and then you need to know what their health needs are. But we don't incorporate these measures into our surveys. We're starting to. There's a fiscal thing. As I said, with all of those failures, all of these crises, when you end up homeless, when you end up in an emergency room, those are high costs, right? Those are drivers of cost. And so while cost imperative is not our number one thing that's driving this work, it's certainly something that we use and calculate to get policymakers in the room, to get politicians in the room, right? Because they care about stuff like that. And then there's systems transformation issues, right? We're talking about making primary care, making services more patient-centered, client-centered, human-centered. How do you do that if you neglect these populations of humans that you don't know much about, right? What can health systems do to increase this visibility? They can screen and normalize. How many of you know about the HIV experience in this country? Read about it, right? It was normalized through our health systems in many, many ways. It was normalized by a lot of actions outside of health, but health played a huge role in normalizing this through our routine screening, right? It wasn't just special clinics and infectious disease and sexual health clinics asking questions about sexual behavior and HIV status. It became routine part of primary care. If you look at, and I trained under some of these people, if you look at the real forefathers of HIV treatment in this country, they're not infectious disease people. They're primary care doctors, because these were the folks seeing people on the front lines before it was known that this was an issue, right? Reducing barriers to access to care, creating safe and welcoming, trauma-informed environments, increasing connections between clinical and community systems. As a provider, perhaps the most frustrating thing I deal with on a daily basis is knowing that I can't help. I can give you a medication, I can give you a follow-up plan, but I can't solve your homelessness. I can't fix your benefit status. I can try, I can help. I can't fix your documentation status. I'm powerless, and there's nothing worse to a clinician than feeling powerless, right? But what we can do a whole lot more. And some of it is structural, I can't do much about that. Some of it is ignorance, willful ignorance. Health systems need to form connections with social systems that are stronger, better, and much more dedicated. What does that mean? It's like when you know that someone's having housing issues, who's your supportive housing provider in the community? Right now, most of my colleagues out there, most of your colleagues out there don't know that. We don't know who to call. Even our social workers don't always know who to call. Because clinical systems say, well, I only go with what's reimbursable by Medicare or Medicaid, and that sphere of influence ends here. But people exist out here. They exist for, what I like to say is, I like to care about the 23 hours and 30 minutes that you're not sitting across from me at my table, right, or in my office. But we don't have a lot of visibility into that, and we need to do better. And then, of course, advocacy and education. When clinicians and health systems coalesce around these ideas, how many of you are following this public charge debate? Do you know what that is? Who can tell me what it is? I'm going to start calling them. Sorry. You know it. What's the public charge? Can I call you out?
So I know about it in terms of like food policies.
Yeah.
So, like people who have used SNAP benefits,
Yeah.
or like eligible to use SNAP
Yep.
benefits, will not be eligible for citizenship.
That's right. A public charge has always been there, so make no mistake that we've always had a designation for people that we consider to be basically wards of the state, or like public, recipients of the public dollar for most of their existence, right? We've had that designation. What we've never done to date is link that to one's immigration status, documentation status, and deportation actions. And this administration has decided to do that. So what does that mean? Yes, hi.
It is my understanding of
Yeah.
what I tried to read of the
Sure,
actual
sure, sure.
proposal they're doing is that it has always been there but never really been
That's exactly right.
enforced. And they're trying to not only enforce it and design, but make it really ambiguous so that if you're a permanent resident, for instance, and you're eligible for this services, now they can say, well, you shouldn't because you're an immigrant and you shouldn't come here to be dependent on our services.
You're absolutely right. I mean, it's always been there, and it has always been, you can always have been given the designation as a public charge, but it was never linked to enforcement of immigration status. What's even worse than what you're saying is they're making that link to deportation proceedings. They're saying, oh, you're a public charge, that means you're a drain on our public resources. And so we're gonna initiate deportation proceedings. You're absolutely right. I mean,
May I add something else?
Sure.
What I find really scary is that through the deportation process, the officers in charge of this can also consider your education level,
Yeah.
your contribution to society, what they think it's more like right for society. So that gives a lot of power to individual people to decide or somebody else's life.
absolutely right. Who's worthy? Who's not? What's a litmus test for being an American? We've never had a litmus test for being an American, right? I don't know how many of you saw, I'm getting a little digressed, but how many of you saw, before Al Franken left the Senate, he had a conversation with the French foreign minister, and he asked him, Mr. Foreign Minister, what does it mean to be French? And he said, well, if you can trace your lineage back to one of the old families, like not back to an old family, back to a village, then we can consider you as natively French. And he said, great, but we never, ever, ever have had that litmus test in this country, and we're creating that now through the public charge and other rules. And my point in raising this is to say, what are we seeing now? We're seeing doctors and health systems organize around the public charge. There was just a huge event up in Boston. We've organized events here. The head of our public hospital system wrote a big op-ed in the Daily News about it recently. So when we organize around these issues, particularly because we're seeing a lot of people on public benefits, right, in our safety net systems, our public hospital system, when we organize around those issues, we're pretty effective at times. Why public health and why the city health department? We are cross-institutional, and we think at the population level, right? This is not just about services. This is not just about you or you or you, it's about all of you. It's about the collective populations that we're missing. And because we're a public agency, because we're a city agency, we have the opportunity to not really be bound by any one institutional constraint, right? If I'm working with NYU Langone, they've got their own issues. If I'm working with the public hospital system, they've got their own issues. But what we can do is convene all those people together and say, let's think broadly. What can apply to all of you? What's specific to you? What's specific to you? But we do well as public health when we bring the clinical system along, when we advocate, when we're strong. We're not as good in public health when we're waiting for the clinical system to lead us. And so I think this is a point of advocacy. 2, we can really, 3, we can establish new best practices. I know in my training, I got very little to no education on refugee health, on homeless health, on criminal justice and health. Very little to none, right? The specific needs, the specific lived experiences. I took care of a bunch of homeless people. I took care of people who were shackled and coming out of the correctional system. I took care of people who were undocumented, but I didn't actually learn. No one taught me. I had to educate myself on these issues. And that's a real missed opportunity for our clinical systems to do better and to do right by these patients, right? 4, we have data. We have data access. We do tons of surveys. We do epidemiologic surveys. We do vital statistics. We have huge population-based surveys. Every time you see a map, and I'll present maps, it all comes from the City Health Department around New York. And we have a responsibility to all New Yorkers. So when we miss out on populations, like the ones I talked about, we fail, right? If we're saying we're doing right by every neighborhood, except for these, we fail. When we say we're doing right by all New Yorkers except for those with, different immigration status, well then, no, those are New Yorkers too. At least by the definition of this administration and administrations past. So what I'm going to do today a little bit is talk through criminal justice and health as a use case, as an example of how we're doing this around one population and how it applies, that model might apply to other populations. Before I go in, questions, thoughts on what I've said so far? Okay, great. We have the highest prison population in the world. Fact, 2.2 million people incarcerated at any given time. Might not sound like a lot compared to 350 million people in the country. Is it 350? It's more than that. It's more than that, right? But roughly. But it's so much more than any other industrialized country in the world and more than middle income and lower income countries, right? So we've decided this is a way we are going to create an underclass. It's an extension of our historical roots, right? Original sin. That's my view, right? Mass incarceration. 700% increase in 1970. Have you guys seen this data? Do you know this data? Okay, good. So we ticked along with a fairly reasonable, low prison population. We can argue about what's reasonable. We can argue about whether we should even have prisons. Different argument, totally good argument. But this, we can all agree, I think, this is perverse, right? Did we all of a sudden become a safer country? Or sorry, a more violent country? Or a less safe country? What does this tell us? In New York City jails, in New York State prisons, and in U.S. prison system, the majority of people are black men who are incarcerated. Vast majority, right? Do you know how many, 2010 census, what's our population of whites, Caucasians? Nationally. Does anyone know? 76%, 75%. We're still a fairly white country. It's going to change. By around 2040, they're predicting a massive demographic shift where whites will no longer be in the majority, right? But right now, we're still 75%, roughly 70-75%. And yet we're incarcerating. So we're really targeting black men, young black men in particular, right? I can do a whole lecture on the history of this, but what the point of this slide is just to show. Yes, please.
I think that's a fair point, but I think your comparison is, like you said, it's your New York City jails, and then you used a demographic that was United States, so that sounded a little unfair.
It's not unfair. I mean, we have a more racially diverse city, which could explain why we have more black men in New York City jails. But we also have 60% of our jails black men across the country, right? It's only 20% of the population. Black people are only 20% of the population, yet we're incarcerated. Our jails are comprised of 60%. So I think, I hear what you're saying, but I think that the comparison still applies. The numbers change, but the disproportionality and the targeting remains. Does that make sense? Okay. So the history here is long. We can talk, people argue about why, but a couple of key things can explain this curve. I mean, there's been a lot written. How many of you have read Michelle Alexander's book, The New Jim Crow? Anybody? Read it. You gotta read it. If you're gonna go into public health in this modern age, you need to understand the historical legacy of slavery in this country, right? And how our mass incarceration system, our criminal justice system, has perpetuated this through a new kind of Jim Crow. Everyone know what Jim Crow is, right? System of laws, post-slavery, to subjugate and create a black underclass in this country. Well, we've just transferred that into a set of institutions in our criminal justice system. But we also combine that with very, very strict drug laws, right? The Rockefeller drug laws were just one example, but you guys are a little young to remember Nancy Reagan going on TV and saying, don't do drugs. You probably watched Narcos, right? I love Narcos. That's very good. But I remember that from childhood, right? I remember that, don't do drugs. I remember DARE programs in my elementary school and middle school. Right? Do they still have DARE programs? No. Anyway, and don't think this is not a bipartisan issue. It's not just Republicans to blame for this. So for those of us thinking that for those of us who identify as Democrats thinking we're not to blame, 1994 was President Clinton. He created some of the strictest additional drug laws since the original Rockefeller laws, right? 3 strikes and you're out. Remember that? Do you know that phrasing? And then we saw also a phenomenon of prison privatization, allowing corporate interests to come into a public sector. All of this driving incentives, driving regulations and laws to incarcerate more people, right? Again, we can explain why, but where are most of the state prisons? Are they in New York City? No, they're in upstate, right? It's a big jobs program. So there's a lot of politics behind this that we don't want to get into today. Sorry, you had your hand, was that right?
Well, also,
Yeah.
I had a professor argue that because the census chooses selects very little at that time, a jail can be a residence. So you're kind of transferring the black population upstate where they can't vote, but they're because they're in jail upstate, the upstate communities get more representation in Congress.
That's right. No, absolutely right. That's absolutely right. They're not counted formally, right? But they're counted in total population. So it's like you've got a predominantly white population surrounding the jail, incarcerating a predominantly black population inside the jail, and the people voting, you're counting the entire population, but the voting interests are only of the people who are not incarcerated, right? Because incarcerated people don't have the right to vote. All right. Got through the polemic part. What are the facts? Why is this a health issue? What do we know about the criminal justice system and incarceration and its impacts on health? Well, we know that most of our data, first of all, comes from formerly incarcerated people. Why? Hard to do research inside a jail or prison, right? So we have some data on correctional health, but we also know that correctional health is a pretty fraught system, right? It's not like going to your clinic down the street. It's a very different model of care. And so we know that first 2 weeks, first 2 or 3 weeks, and the first year after coming home from incarceration are really the most vulnerable time. They're the time at which you're most apt to pass away from a whole host of reasons. In the first 2 weeks, what do you think it is? What do you think might be driving a 12-fold increase? What would the top 1 or 2 causes be?
Suicide?
Yep, number 2. Violence and suicide are taken together. Gun violence but violence of any kind is number 2. Number 1? Yeah, please. Sir.
You can afford to sustain all the big disorder.
Bigger issue, but might not kill you so quickly. But definitely, yeah, that definitely explains the 4 times, can explain some of the 4 times increased mortality in the first year. What about the first few weeks?
Access to medication or drugs.
Drugs of a different kind, substance use disorder, right? Imagine you've got an active substance use problem. Most jails don't have really well-functioning treatment systems, medication-assisted treatment systems for something like opioid use, for example. You've been denied that medication, that substance for months. And then all of a sudden you're back home, and if you even take a little bit, your tolerance has gone down so low, your risk of overdose is exponential compared to when you went in, right? For those of you who know anything about opioids, heroin, and the like, prescription as well, it's all about tolerance and building up levels of resistance almost, right? So drug overdose, violence. In the first year, guess what's the number 2 cause? Cardiovascular disease. Isn't that crazy? Right? So from a physician's perspective, that's super crazy because what's the age of most of the people coming home from jail and prison? Younger, right? 40s, 30s, 40s, some in the early 50s. When do most people get cardiovascular disease? 60s, 70s, 80s. It's a disease of older age, right? So that means, and there's data to support this, there's a premature aging hypothesis, right? That people are getting older more quickly. They're developing diseases of old age. And we see this in chronic diseases. 40% of incarcerated individuals have at least one current chronic medical condition. Incarcerated women have higher rates of cervical cancer. Men, lung and liver. Traumatic brain injury. 50% of men and 40% of women in our jail system here in the city have a history of TBI, right? And that's to say nothing of the risk of TBI once inside, right? Through violence. Trauma and behavioral health, right? Sexual abuse, diagnosable substance use disorders. So much higher than the general population. I went back here and I showed about the deinstitutionalization. I didn't really expand on this, but that's deinstitutionalization of our mental health system. Right? We used to have, God, the word's escaping me. Mental health hospitals, or what they used to call them, asylums, right? You guys know Batman, Arkham Asylum, right? We used to have these mental health, they used to call them crazy hospitals. People who have serious mental illness, they used to put them away in institutions. And under Jimmy Carter, he said the process started in the 60s, but he really accelerated it in the early 70s. They said, look, this is not a humane process. This is not, and he was right. It wasn't. Those institutions were not humane. So they deinstitutionalized everybody, but they didn't have a plan B. They didn't say, we're going to reinvest in community mental health, we're going to create all these community hospitals, or we're going to train a whole mental health workforce. No. So for 30, 40 years, we've been basically having people with serious mental illness living on our streets, living in our shelters. It's hard to sustain yourself when you have serious mental illness. It's really hard. It fractures lives, it fractures families, and they need support. People need support. And if institutionalization wasn't the answer, but then you needed to have an alternative, and only now we're trying to play catch up, and it's really hard, right? And so the criminal justice system has become that offshoot, right? Like we can't put them in a mental hospital, let's just put them in our jails. So you go to Rikers Island, tons of people with mental illness in Rikers Island, upstate. Questions, thoughts? Yeah, hi.
I used to work in a jail.
Yeah.
And what happens is
Where?
that in San Diego.
Okay.
So what happens is that people with severe mental issues ends up doing something, comes into jail. Sometimes they already have a history of what treatment they need, and they get treatment in jail. They get better, they get released. But then when they go out, they don't have
Connections in the
access.
care. Yeah, absolutely.
They struggle with everything else we talked about on top of their mental illness, and then they end up coming back.
That's
and
right.
then it's a cycle that happens.
That's right. That's absolutely right. So we've definitely created these pipelines that just keep cycling through because we don't know where to intervene. And from the healthcare standpoint, imagine that, right? So folks are showing up to our emergency departments at higher rates compared to the general population, right? Far more likely to be for mental health disorders, substance use disorders, and ambulatory care sensitive conditions. What does that mean? It basically means things that could have been treated in a clinic that you're showing up to the emergency department for. So that's a cost issue. But here is just a care issue, right? You treat someone, you stay, what do emergency departments do? How many of you have been to an emergency department here in the city? Anybody? Thank God. I trained here. Challenging place. But what do? They just stabilize you, make sure you're not dying, fix whatever they can fix, and then send you home. That is not what people with serious mental illness need, right? They need continuity, they need long-term care, they need medication and therapy. They need behavioral, they need group therapy, they need a whole lot of supports that we don't provide because we keep them on the margins of society, right? High rates of healthcare system mistrust. One study showed that 42% of men, formerly incarcerated men, reported that they felt some form of discrimination in their primary care system on the basis of either their race or some sense that their criminal record was known. Right? So does that make it a place you want to go? I wouldn't want to go. If I knew I was going to go to a place and get mistreated, I'd go to the emergency room, where at least they barely know my name, they don't know who I am, they don't ask a lot of questions, they're just trying to treat me and street me, as they say. That has a lot of systems effects, right? So I mentioned, so this is the why. That's the why we're doing this. So now let's get into the how. So it starts from the health department's perspective with measurement. We do that very well, right? So what's very interesting is that, how many of you know that the mayor committed to closing Rikers Island in 20 years? 10 years, sorry. You knew that, okay, good. So what does that mean? Right now we have the lowest daily census at Rikers Island that we've had in years, but that's still a lot of people to be sending home with what supports, right? What are we doing for folks that we're going to close that prison, we're going to close that jail, sorry, and then what happens? We need to start asking that question, and then what happens? Yeah, go ahead.
Can you just differentiate for the class between a jail and a prison?
Oh, yes, jails. Local, city, county, right? Local municipalities, prisons, state and federal, right? Majority of prisons are state. Federal prisons are these big most of them are like these big supermax, you heard of these, and like these high security, yeah?
Why would you get sent to jail instead of prison?
Yeah, very good question. You get sent to jail when you've been arrested, but not, sometimes you can be just detained and not charged. So let's say you get picked up on the street walking out of class, someone doesn't like the look of you, right? Where are they going to take you? They're going to take you to central booking, which is down on 100 Center Street, underneath the courthouse. They call it the, what do they call it? The catacombs. And you might stay overnight there until you see a judge in the morning, or they might just take you right up to Rikers that night, and you stay there for some indefinite period of time until you end up on a judge. Not been charged with anything, not done anything wrong, who knows? God knows what you must be seeing up there at Rikers. Right? So people in jail, detained before charge, arrested and charged and awaiting sentencing, in the middle of a court case, can't make bail. We have cash bail in this city, right? It's regressive. Who can afford to pay cash bail? We can. Not most people, right? And also people who have been sentenced to less than a year. Right? If you've been sentenced to more than a year, you're quote unquote going out of state in our city county system. Now, you might go in front of a judge, or you might see a prosecutor who says you've committed a federal crime. This is where my knowledge breaks down, because I'm a doctor, not a lawyer. So God knows what a federal crime is. But a lot of gun charges, drug charges, maybe they want to pick you up as a part of a larger sting around sex trafficking or something else. Then you go to federal court. Then you see a federal judge, and then you can go to federal prison, right? You still might be in Rikers while you wait. but your destination might be different. So that's just a distinction. Right now, we're just talking about New York City. Okay, so the jail population is declining. That's a good thing. That's through a whole series of procedural changes on the criminal justice side, right? Like, how many of you know what stop, question, and frisk is? Stop and frisk, commonly called. Well, that was policy under the previous administration. That was ended by this administration, and we've seen a precipitous drop-off in arrests and such. Things like the current DA's decision not to prosecute turnstile jumping or marijuana, right? We haven't legalized marijuana, but our DA said, I'm not going to prosecute. That's good, right? So all those things will slowly drop. And we look to other jurisdictions in the city too, in the country and to figure out what to do on that regard. But that's only part of the problem, right? You have people in jail who have a lot of needs and are at high risk of, do you know what the word recidivism means? What does recidivism mean? Anybody?
Going back to prison?
Yeah, I mean, recidivism is a general word. It means going back to anything, right? It means doing the same thing over again. What's our recidivism rate in the country? Anybody? No? It's like 70% within 3 years. That means once you go to jail or prison, you're likely to go back.
I can't quote the research, but I remember a common topic when I worked in jail is that for every day somebody spends in jail, they're more likely to come back if it's their first time. Depending on the time they get the first time, they're more likely to come back.
I wouldn't doubt it. I don't know the research either, but I wouldn't doubt it. Right? Because if you're there overnight and then you get released, that experience on you is no way as traumatic as someone who's been upstate for 7 years. Right? Or in solitary confinement. There's a whole host of things that happen inside jail and prison that I'm not going to get into that have effects on health, though, that we'll talk about through trauma. What we need to do then is to start talking about this as a public health problem. I brought my maps. That's what we do, right? These red communities are the communities with the highest jail incarceration rates. This is old data from 2014, but we're collecting new data all the time on this. These are also the same communities that face disproportionate poverty and disproportionate premature mortality, right? No surprise. We are pulling poor people from their communities, incarcerating them, sending them back into those communities without supports, and then wondering why it keeps cycling back and forth. We are getting exactly the outcome we set it up for, right? We need to shift it towards a public health approach. We need to measure these things at the community level so we can intervene at the community level. So it starts with measurement, right? We need to move towards this basic public health framing. Risks, exposure, and outcome, right? The risks in this case is a whole host of factors, right? That correspond with a whole lot of other factors, right? They correspond with where you live, with your race. These are all positively correlated things, right? But the exposure, we need to start thinking about criminal justice involvement as a negative health exposure. Because once we start doing that, we can start looking at the response variables, the health outcomes, and start linking those things, and then look at exposure mitigation as a strategy to improve health, right? And bring a health conversation into a discussion that's largely been procedural, legal. It's just like, do things differently, police, do things differently, lawyers. But we can actually offer solutions at the health side. Does that make sense? I'm happy to answer anything about this. So these are our community districts, right? New York has, is it 500? No, there's more than that. Anyway, New York has a bunch of community districts. We divide up the city in this way. And that's how we measure health at the more granular level. And so for the first time since 2004, which we just did on a one-off, we're actually measuring criminal justice involvement at the population level, and we'll be putting out that data in early 2019. But I can tell you this, 1 out of 3 New Yorkers, from that data, 1 out of every 3 New Yorkers have some sort of history with the criminal justice system. That's either direct or indirect through a first-degree family member, that's either incarceration or some other form of criminal justice system involvement. Police involvement, court involvement, probation, parole, right? We're not going to get into that entire system, but my point is that if you said 1 out of 3 people smoke cigarettes in this city, you would run after that problem, right? That would be the #1 problem on the mayor's mind, on everyone's mind. 1 out of 3 people have been touched by this system throughout their lifetimes. That's a pretty big problem. It's much bigger than just 8,000 people in Rikers today. It's much bigger than 2.2 million people in jail at any given time, right? It's a long reach of this system, right? That's cross-sectional data, right? You guys are epidemiologists. That's just a prevalence estimate. So we have to think about children as well. We have to think about the effects of incarceration on children of incarcerated parents, right? What do we know is associated with having an incarcerated parent? Well, we know it's an adverse child event, which we'll talk about later. We know that it's associated with poor school outcomes, whether that's performance related or discipline related. It's related to behavioral instability. It's related to mental health, depression and anxiety. It's related to physical health problems like obesity. So if that's not a health crisis for the next generation, what is? You talk about the same thing is true for the child separation that's happening at our border. That's a traumatic event. That has lifelong consequences for that child, right? It is just about the morality of it. Central is the moral question of separating people, whether it's through our system of incarceration or child separations at the border. But the effects are much more than long-term. After reunification, the healing is lifelong, right? Also, female partners of incarcerated men, higher rates of chronic diseases and behavioral health, higher rates of a whole host of issues. And there's currently a birth outcome study being done with folks at Cornell to look at what are the birth outcomes of women with an incarcerated spouse or incarcerated partner, right? It's more expensive, so we have to define that as well. Look at the cost of care. This is a reference population, age, sex, and race matched. We did this analysis and we're publishing this currently. Non-jail exposed, right? So let's look at that risk exposure outcome. The moment you have even 1 jail contact, you're immediately 3 to 4 times higher in your costs, your healthcare costs, right? These are Medicaid costs, right? If you're in the top 10% of jail people frequently incarcerated, you're 5 times as expensive to the system writ large, right? So that means, what is that a function of? The further marginalized you are, the more high-cost care you use. Incarceration further marginalizes people, and so it diverts them into high-cost, low-touch, transactional forms of service engagement, like emergency departments, which cost everyone a lot of money, like inpatient hospitalization. What's an inpatient hospitalization usually a function of? Something that wasn't caught in the community, right? Something that wasn't prevented. As I said, so number of hospitalizations per year, 0.16 of a hospitalization isn't really meaningful, but you can see the moment you touch the system, the criminal justice system, in this case Rikers Island, you're bound to have an annual rate of about 1 hospitalization a year. How many of you have been hospitalized once a year? None of us, right? Most of us are healthy, I hope. And that's a lot. That's a lot. You know, so as soon as you're in the higher cost category, the higher jail touch categories, you're up to 1.5, 2 times, right? Okay, so I've laid out the problem for you. I've laid out the population data. Now the question is, what's the response? Well, as I said to you earlier, we don't prepare our clinical workforce, and I don't just mean doctors. We don't prepare anybody who comes into contact with patients in healthcare settings well to deal with the issue of criminal justice system involvement, right? So what are we doing? These are city health information bulletins. These are our public health detailing kits where we go directly to primary care sites and work directly with clinicians, train them, build their capacity. These city health information bulletins go to 25,000 clinicians or something like that, 22,000 clinicians a year across the city, right? So it's about getting information and skills into the hands of people who are bound to see patients. I told you 1 in 3 people have some history with this system. So these are, whether or not, if you're a provider out there in the community, whether you know it or not, you're caring for folks involved in the system. You just don't know it, right? There's no systematic way of screening or asking that question. We're doing training on all sorts of levels for providers, as I mentioned, for community health workers, for communities themselves. One thing we have learned in our focus group work with justice-involved people is that there's a lot of misconceptions of why it's important to engage in care, why it's important not to go to the emergency room, for example, and to go to develop a relationship based on a primary care provider. We're developing new programs to support health systems and to create new clinical and community linkages. We talked about reentry. Who mentioned the thing about jobs? And it was you, I think? Sorry, who mentioned about the difficulty in coming home? Reentry? Was it you? I'm looking at you. I'm pointing at you. Was it you? Or one of you? Anyway, sorry. Fine, it was you. We'll say it was you. Think about the suite of things that anyone's facing, right? The moment you get home, you get released from Rikers. You know Rikers is an island. It's in the name. You get driven over the bridge. You get dropped off. Some people get dropped off up at 125th Street. And then what? You gotta like rebuild your life from scratch. If you're lucky enough to have a house, a place to stay, a family member who will take you in, you might have that ticked. A lot of people don't. It's on the order of 25%, 28% of people go directly from Rikers Island to a shelter, to one of our city shelters, right? Food security, where's my next meal gonna come from? Job, how am I gonna pay my bills? Or how am I gonna like have enough money to just live a life? How am I gonna get around the city? What are my conditions of supervision? So do I need to meet my parole officer every week and pee in a cup? Do I need to go to my probation visits? Safety issues. Am I going back to a community where violence is prevalent and where I was involved in violence and now I'm at risk of getting more involved in that again? And of course, health. Health is sometimes the last thing that people are thinking about. Right? Amongst all those things, if you don't know where you're going to eat, where you're going to sleep, if you got clothes on your back, or can pay for any clothes, do you think a healthcare visit's like the number one thing you're thinking about? Probably not, right? But that's a missed opportunity, right? Oftentimes we have good connections into programs for substance use disorder, for mental health, for HIV treatment, Hep C treatment, because we have an vested interest from a public health perspective in keeping those folks connected into care. But what about basic primary care? What about developing a relationship with the community-based provider? What about taking care of all of you, prevention? What about avoiding those ER visits and hospitalizations I talked about? So how can primary care break that cycle? How are we doing on time, by the way? Does anyone know?
Okay, we go into 6:35.
And where are we at?
We're
Sorry.
5:47.
Oh, great. So how can primary care intervene? Well, we think primary care systems, when structured with social services, can help break that cycle. So we developed the NYC Health Justice Network, which is going to start enrolling clients in March. And that's a partnership between community-based organizations that care for people with justice involvement and their families, and primary care clinics. Oh, this arrow came out faded, but it's founded on a one-to-one relationship with a peer. So imagine you come home, you got to navigate that whole suite of things, but someone's meeting you at the doorstep. Someone who's just been in Rikers. Someone who knows exactly what you're going through. Someone who's from your community. Someone who might be of your age, or a little bit older even, and someone who can like sort of walk you through it. We know a lot about community health worker programs, right, from the global literature. I spent 15 years of my life working in places like Haiti and Rwanda on community health worker programs for Partners in Health. And so we just brought that same model here. The difference is that And who are our most effective community health workers for TB patients and HIV patients in Rwanda and Haiti? TB patients and HIV patients, people who are taking those meds themselves, right? You cannot underestimate the power of lived experience in forming connections, right? And connections and relationships is ultimately what determines who succeeds and who fails on reentry in this case. And so we're doing a whole bunch of stuff to help this system. We're going to be working here in northern Manhattan, but we're already expanding throughout the city. We have a bunch of partners, some clinical, some not clinical, and we're really happy to be working with NYU as well through a CDC grant. We're measuring things like I talked about. How much primary care utilization? Are patients more satisfied with their care? Are providers more satisfied? Is there an increase by virtue of more engagement into primary care? Is there more social service engagement? And then of course we're looking at things like costs and recidivism. Throughout all this work, we make a really clear, specific, and dedicated effort to incorporate the voices of affected people into our work. That's a commitment of our bureau, a commitment of our agency. Part of how we do that is through human-centered design. How many people know what that is? Design thinking. It's very sexy terminology. It's usually used for tech. It came out of Silicon Valley. It was used to develop the first mouse. It's basically asking the question of IDEO was a for-profit firm that developed the first mouse, developed the first computer monitor, the first Mac, sorry. And they basically ask questions of basically simple questions like what would you like to use? What would be easy for you? How would you like to experience this situation? They spun out into an organization called IDEO.org, a nonprofit that's looking at social problems. We're working with them to ask the same questions. If you're a justice-involved person, if you're a refugee, if you're an immigrant, if you're a chronically homeless person, what do you actually need? How would you like to engage with it? How would you like to experience it? What can we do better? What should we be doing differently? How often have you heard public programs or programs of any kind really asking those questions? I think that's a pretty big innovation. We haven't yet seen the fruits yet because we're just starting. But that commitment is embedded throughout everything we do. Human-centered design starts with this question. What's desirable to people? Normally, we look at what's feasible. That's usually the technical question. Like what can you do? What can you program? What can you operationalize? And what's viable, meaning what's financially sustainable, what we can pay for. But very rarely do we start here, right? Desirability. What do you actually want? And there's a lot of demonstration projects from around the world where for social good that can be really powerful. So we're trying to incorporate that a little bit. And we're doing a bunch of research. I'm not going to bore you with that. And we're going to do more stuff. This is not so much for you. Okay. I told you that we are working not only with the justice involved, but with other populations that share similar profiles and risks. What are those risks? What link these populations together? Trauma, number one. They've all had histories of trauma, whether as children or as an adults, whether acute trauma through violence or some other form, or collective trauma through what you see and experience and live in and with every day. And we know a lot about trauma and its health effects. What we don't know a lot about is what to do about it, right? And so we're trying to figure out what to do about it. They're all disproportionately ill from an epidemiologic point of view. They all have disproportionate burdens of illness. They all are really socially complex. As I said, they're dealing with that whole suite of issues. They're all very expensive, looking in that very pragmatic lens, right? They cost us a lot, which is not the best way to frame it, but it's important for policymakers. They all exist at the margins of society. We push them there, we leave them there. And they all face very unique barriers to care. So there are some very basic tenets of, for example, our NYC Health Justice Network that will be useful for all of these populations. there's going to be a lot that's very specific. And we're going to have to develop that specific expertise in our healthcare systems. This is just a quote that I really like from Don Berwick. Don Berwick was President Obama's first appointee to head the Centers for Medicaid and Medicare Services. He was never confirmed because he was too much of an activist, and then he left. But he said this: in my view, the biggest travesty in current U.S. social policy is not the failure to fund healthcare properly or the pricing games of healthcare companies. It's the nation's criminal justice system, incarcerating and then stealing the spirit and hope of by far larger proportion of our population than in any other developed nation on earth. If taking the life years and self-respect of millions of youth, with black individuals being imprisoned at more than 5 times the rate of whites, leaving them without choice, freedom, or the hope of growth, is not a health problem, then what is? And this was a call. He wrote a paper in JAMA, the Journal for the American Medical Association, as a call for the moral choices of physicians, right? And he says the work of a physician as a healer cannot stop at the door of an office, the threshold of an operating room, or the front gate of a hospital. The rescue of society and the restoration of a political ethos that remembers to heal have become the physician's job too. I really find that to be powerful as a physician, but I think as all of you, whatever you go on to do, whether you work in public health, social work, I think you can relate to that idea that these social problems that we feel are too big to tackle as service providers, too big to tackle as frontline people, are actually our problems. And the more we engage through strategic programming and advocacy, the better. Okay, questions there? I'm going to take a little bit of a shift. Are we good on time?
Yes.
Okay, this shouldn't take too long. We're going to talk about trauma. And we're going to talk about a little bit about resilience, but mostly about trauma. It's a very hot topic in healthcare. It's a very hot topic in public health because we know a lot about it. There's something like, I've heard quoted, around 11,000 papers written in the literature about the connections between trauma and health. And yet we do nothing on it. We don't get trained on it, really. We don't intervene on it. There's a couple of examples. If you have time, read a piece from a few years ago about a woman called Nadine Burke Harris. Watch her TED Talk. There's a New Yorker piece about it from a few years ago in her clinic in San Francisco that treats ACEs, which we'll talk about.
Do you remember the full name, please?
Nadine Burke Harris. Yep. Okay, basic science. Ooh, back to science. Back to science. How many of you studied science, by the way? Okay, pretty good number. I studied economics, so that's why I wasn't really a scientist. Still not. Early life adversity, right? There's a whole host of protective factors to that. Income, race, education level, parents' education level, whatever, nutrition. And there's also predisposed vulnerabilities to that. But we know this pathophysiology super clear, right? This is like smoking gun research. This is like seatbelt save lives research. Like in terms of the data of how this all works. It works on your brain, works on your hormones, it works on your immune system to create a whole host of health problems. It affects your brain by affecting your executive function, your thinking, your organizing, your stress response, your memory, your survival instincts, right? When you meet someone, I've taken care of people coming home from incarceration, for example, or even taking care of people in Rwanda who were genocide survivors. There are certain things that you might say or do, or unintentionally, obviously, that will trigger them. And then they will immediately go into this stress response. And you have no idea what you just did. Because I was not prepared, I was not trained, I didn't learn any of this until I did this work. Now imagine that, right? Imagine you're the patient, you're the client, and I do that, and you have this response. Are you going to go back? Probably not, right? You're not going to come back. You're going to go to the emergency room or we'll just leave you alone, or something else. right? It affects, it makes your body continually defend against threats even when there are none present. Your executive function becomes diminished. That means your decision-making ability becomes diminished. Your self-sensing system becomes blunted. But that's just the brain-body loop stuff, right? It has a whole host of impacts on chronic disease, mental health, adverse child experiences. Has anyone heard that phrase? Sounds like you have. There's a set of 10 ACEs they're called. They're traumatic experiences, adversity faced in childhood that have unique neurologic and immune and endocrinologic effects on children and long-term effects, right? It's a universal experience, right? This Kaiser Permanente study was in a wealthy, white, suburban part of the Bay Area. And 64% of people reported having at least one traumatic event. 4 traumatic events was associated with a vastly disproportionate rates of mental health issues, chronic health issues. Right? So we know that the stuff that happens to you as kids, the stuff that happens to us as kids, has effects on our health as adults. Right? And there's a whole host of categories here, right? It's not just about what happens immediately, it's about your behaviors, right? So when we talk about chronic illness, there are some native effects like on your blood pressure and your endocrine function that make you at higher risk for diabetes and heart disease and hypertension. But there's also risk behaviors, smoking, risky sex behavior, substance use, suicide attempts. These are behaviors that are disproportionate in kids that have suffered ACEs, right? Chronic medical conditions. I encourage everyone to watch a 60-minute special with Oprah from about 6 months ago. She grew up in Milwaukee. She grew up poor. She grew up in a house with some, I think, domestic violence, maybe sexual violence. And she was asking the question, and the whole story was about ACEs and trauma in kids in Milwaukee and what this program was doing to treat it and to raise up this as an issue, raise this up as an issue. But she also talked about like what made her succeed versus some other people, right? Like what are the protective factors, the resilience. And ultimately, it came down on the idea that what changed Oprah's trajectory, like many, is that she formed a relationship, a bond at some point in her childhood after all of those adverse events, or maybe even while they were going on, that redirected her course. She's no different than those kids, right? But we tell these stories about like bootstraps and resilience from the perspective of the individual and, well, Oprah's just gifted. Those might be true, but like actually she had people in her life to help redirect her, right? And so when we talk about these conditions, we also talk about like people's access to good relationships and to good systems and structures while they're dealing with this. It affects life expectancy, right? 20 years earlier on average with people with 6 or more ACEs, highly traumatized people. Trauma is experienced at the individual level, right? Incarceration being one, but also at the community level. And we know very little about that stuff, right? We know about this stuff, but we don't know a lot about its traumatic effects. We're studying it. Sociologists are studying it. Public health people are studying it. We know more about the individual effects. People with justice involvement experience higher rates of trauma. Immigrants, migrants, refugees. So now you see where I'm getting at, right? You see how the work we're doing with the justice involved is a way to link all these marginalized special populations together. People who have served in the military have a high prevalence of ACEs and PTSD. So note that when I say trauma, I am not talking about PTSD. PTSD is a very specific clinical diagnosis that has a very specific clinical treatment, behavioral and clinical treatment, right? It's different to trauma. Why is this important for healthcare? Well, as I said, it has Trauma is a prevalent exposure. It has a lot of impact on mental and physical health. It's very difficult for patients who are traumatized to engage in healthy behaviors. So my role as a primary care doctor, anyone on the front lines talking to people, counseling, social work, you're going to be dealing with the effects of risk behaviors and how to coach and motivate and counsel people through that. For example, I see a patient who's morbidly obese in my clinic. I ask her what is she struggling with her eating, right? Yeah, some of it might be genetic, some of it might be something else, but she's obviously not eating the way she could be eating. And so I ask her about it, she tells me, and then I give her a recommendation about how to eat better. How many of you, what's the success rate of that intervention? Guess, just take a guess, percentage. Yeah, something on the order of less than 10%. What we've not done yet is start to ask, what are you treating when you eat? What's the pain? What's the trauma? Why do you eat like that? What does it make you feel? Does it make you feel better? Does it make you feel sadder? When you're eating in that way, or smoking that cigarette, or taking that extra drink, are you treating a pain that we can link to something that happened to you? And then can we work through that together, or through counseling, or through, right? At the end of the day, we're social and mental creatures whose behavior manifests in physical ways, right? So we have to get to those roots, but as clinicians, we don't think of those things. As healthcare systems, we don't think of those things. Not systematically. These are just, so the SAMHSA is out of the Health and Human Services Agency. It's the Substance Abuse and Mental Health Service Administration. Anyway, it's our government and federal government. And they've started to take notice of this, right? Well, at least in the prior administration. And to define what it means to create a trauma-informed system. Again, those sound like really good things, very hard to do in practice, and like no one really knows what the implementation of that is. Should you be screening for ACEs? Up at Montefiore in the Bronx, Albert Einstein, they've integrated systematic ACEs screening at 100 primary care sites. Pretty good, right? So they're going to be publishing that stuff. Training of workforce, doing trauma-specific interventions, referral systems. I mean, there's a whole host of things. What are the types of triggers in a clinical environment? TRIC is trauma and resilience informed care. Loud noises, bright lights, crowded waiting rooms. How many of you have been to, I work in a Medicaid and uninsured clinic. It's not a friendly place, right? I don't go to get my care there because I wouldn't like it. It's crowded, it's loud, people can be yelling. People are stressed out, people are tired, people are waiting a long time. Everyone's doing the best they can. So it's not about blame, but it is what it is, right? Like we create these environments, can we do better? This is just some examples, right? What can you do for your workforce? What can you do for your patients? You can anybody know what concierge medicine is? Yeah, right. Why do you think we have concierge medicine? Just throw it out there. What? Yeah, that's true. But what do they think they're responding to in the consumer phase? What's the demand? What? Well, I mean, even concierge medicine has clinics. So maybe access, laziness. Relationships, so easy access, right? You want to be able to text your doctor or message them. What else? It's just nice. It's like plants in the waiting rooms, like leather couches, like chill. You don't wait, right? You get a very specific appointment time and you get seen at that appointment time. Busy people. That's what you pay for. We don't do any of that for poor people, right? My patients wait up to an hour sometimes. Right? Hours at times. If they show up late, it's tough, right? Because there's always someone waiting in front of them. It's really tough. But can we create better environments for the most marginalized? I think we can. Anyway, there's a whole set of things we can do. There's also the trauma of working in traumatized environments, secondary trauma, caregiver trauma, vicarious trauma, right? There's a phrase in the sort of trauma world that says hurt people, right? If you don't deal with your own stuff, you're gonna let that out on someone else, no matter what your intentions are, no matter what your good intentions are. You're gonna bring that to your interaction, you're gonna unintentionally let that affect the way you care for somebody. And so the healthcare world and the public health world is also starting to take notice of this as a phenomenon. Are our workforces themselves highly traumatized? Particularly when we're talking about community hospitals and safety net hospitals, which draw workforce from the same communities they're treating, right? So, I mean, there's a lot of wellness work being done in healthcare and public health around self-care. So, just to wrap up, I think that's my last slide. Oh, right. The core experiences of psychological trauma are disempowerment and disconnection from others. Recovery, therefore, is based upon empowerment of the survivor and the creation of new connections. Back to my anecdote about Oprah, right? She formed connections of some kind. They were there for her, they were brought to her, she took advantage of them on her own, all of those things, right? Recovery can only take place in the context of relationships. Ultimately, what we're trying to do on the public health side and the clinical side is to say, how do we form better relationship with the people with whom it's hardest to develop relationships, right? People for whom they have no incentive to form a relationship with you because they don't trust you. And you've done nothing to earn their trust, to deserve their trust, right? The medical system is not a neutral arbiter in this story. There's a long history of racial injustice and systematic oppression. So we need to reckon with that stuff. We need to say, all right, I know that history, but I'm not like that. And I know that I represent this thing, but how can I form a new relationship with you? You gotta come in with that humility. Questions, thoughts? Thank you. You got time?
Yeah. What would you say are, in a similar vein of Don Berwick, if there were a call to action for public health and those entering into...
Climate change. Climate change. Climate change. Climate change.
If
What
you
else?
want to just,
Yeah.
other than climate change, something that a person who is saying, look, I'm going into the public health space, I have a diverse interest, we can have varied interests in this room, but what are like 2 to 3 of the things as a call to action for those in public health?
I think climate change. But when we're climate change. When we're thinking about at the population level, immigration. Our immigration system, care for the undocumented. Talk about a marginalized underclass. How we care for people without quote unquote legal status in this country is a shame, right? And we've tried our best to create safety net systems that are agnostic to this, but it's becoming harder and harder in our current political environment to do that. So I would say that's one. Become immigration experts. 2, criminal justice. Become criminal justice experts. Understand this social failure and how it affects health. Understand that there's a gap that public health can fill in terms of offering an alternative way. We don't need to keep incarcerating people to solve these problems. We don't need to keep incarcerating people to solve our mental health crisis or our substance use crisis. We need more public health. We need more health care, we need more public health, right? Healthcare access is one. Single payer, become single payer experts. Go for the drivers, right? Understand why removing all those financial incentives will change our system, no matter what anyone tells you about incrementalism or Obamacare or anything else, all good things. We need to wipe away the drivers and the incentives that actually structure the system in that way. Those are the big ones, I think. Climate change? Climate change. Yeah. I'd say environmental health too. Look at Flint. Look at our public housing stock. Look at our clean water and look at the EPA regulations that are getting just gutted. right? That has an effect on human health, and we need to tell that story. Public health needs to lean in and step in to these political challenges in very strategic ways, and bringing our tools to bear. What are our tools? Data, measurement, right? Connections into services and care. We know what clinical approaches are, even if we're not clinicians. We know how to leverage that. So those are two big tools that we have at our disposal. We know prevention, right? We know how to interrupt things, find them early and intervene. So these are the things that I think about. Yeah,
Hi, great talk. Thank you so much.
Sure.
It was really illuminating. If you could wave a magic wand to pass a law to improve mental health in New York City, what would your priority be for a policy change?
Very good question. You know, I might create like opportunity zones, mental health opportunity zones or something like that, where, because the intervention to care for someone with mental illness is really complicated. It's counseling, it's medication, so it's healthcare access, it's collective group work, relationship work, right? Like if you have serious mental illness, if you're schizophrenic, you need to have a place to go and like spend time. And you might spend time with other people who share similar challenges. We have stuff like that in the city, not enough of it. So I would make all those publicly funded programs. Increase access to educational opportunities for people with mental illness. Because the idea that somehow you have mental illness and you can't participate in life is just wrong, right? We just have to find new ways for you to do that. Maybe you're not best suited to sit in a classroom for 90 minutes and listen to me drone on, but there's got to be other ways for you to grow and learn and be a productive member. So I think mental health opportunity zones might be one thing, but it's not a one size fits all solution. You know, it's not like healthcare access and then everyone's good, because this isn't a medication issue, or at least not just it. That's one thing. Other questions? Hey.
The ACE program, was that primarily for primary care doctors, or do you think it would extend hopefully to emergency departments?
Yeah. I mean, it started with pediatricians, right? Because they were dealing with kids who they saw were coming from highly traumatized families, situations, right? And pediatricians have this, we call it mandatory reporting function, right? So when you see evidence of domestic abuse, sexual abuse, neglect, you have to report it to the authorities, right? To Child Protective Services or ACS. And so it came out of that world. It has definite functions in all parts of it, right? Because as I mentioned, it's not just about what's happening today to the child, it's about what's going to happen to that child 20 years from now, 30 years from now, when they're an adult. And so when it comes to me, I take care of adults, right? I'm an internist. So it's about me asking those questions in a sensitive way and getting to the root of the problem, right? In an emergency room, it might be, you know, emergency rooms are difficult places, and they're not going to be doing these sort of like ACE screenings on a routine basis, but maybe there are short ways in which we can sort of identify quickly what signs and symptoms are of trauma in an emergency room setting. So the answer is yes. That's a long way of saying definitely should be done throughout, you know. I mean, there was just a study published in JAMA about hospital-based trauma, right? The prevalence of that. Just the trauma of being hospitalized. I mean, like bells. Have you been in a hospital? I mean, like bells and whistles and alerts and people running in and out of your room. You don't know who they are, and it's a crazy situation. Like, I wouldn't want to be hospitalized in anywhere. And so it's traumatic. Like, you have to get over it. And we have to provide ways to do that. Thoughts? Is that helpful? You all gonna work on trauma? Or climate change? Okay.
Well, thank you again.
What's that?
Are you going to share your slide?
Yeah, I think so.
You are?
Yeah.
Okay, so excellent. So I'll be able to share the slides. I won't post them on NYU classes, but I'll share them electronically. There was a host of information that Dr. Vasan presented tonight that will improve the way you practice population health and public health. I had a sense of urgency when I first heard him speak about bringing him in for my students in the fall, because this is when we talk about, I asked the question, where is public health going? Where is health changing? How is the healthcare landscape moving? And this is an example of population health innovation, right? So the response that the New York City Department of Health has to these communities, these vulnerable populations that as they have been defined tonight, is ways in which health care systems must continue to innovate, to meet need and to meet demand. That's one thing I want to say. The second thing I want to say, we've spoken about very briefly, but trauma-informed care being a way that health systems have to become more responsive. So there are just key takeaways that I would like for you to be able to take with you, not just for as you progress throughout the rest of your academic careers, but as you progress throughout your professional careers. And then think about some of these ideas and how you might innovate in our last final team project, right? In the case of Carl Wade and the decision for medical parole or not, thinking about mass incarceration, the system that is mass incarceration, what does a more responsive system look like? How do you innovate in sometimes archaic and dinosaur-like relic institutions? So hopefully this will get your synapses firing and off to thinking. So once again, just